There are three most important questions you should ask before deciding whether to do a dental implant or save a tooth. Number one, is the tooth restorable? Number two, does the patient suffer from recurrent caries? We'll cover the third most important question at the end of this podcast. A 67-year-old patient presents with a chief complaint of loose lower anterior teeth. She wants to know whether those teeth can be saved. She's concerned about the recession on those teeth and what can be done about them. We do the complete examination, and as you go through this, you'll see what I see. Take a look at tooth number 2, and you'll see recurrent caries in the mesial aspect of that tooth. Take a look at tooth number 3. It's had endodontic treatment done, and you'll notice that the tooth has been patched. If you take a look at number 14, take a look at the apical lucency on that tooth. And now as we look at the lower tooth, tooth number 18, you'll see an apical lucency on that tooth. If you take a look at tooth number 30, you can't see it here, but there's a crack on the distal buccal cusp. And if we take a look at tooth number 31, there's impingement upon the attachment apparatus. Let's take a look at the occlusion, and that's why it's important for us to look at the occlusion on the CT scan. Notice we take all of our CT scans in occlusion, and let's take a look at those lower anterior teeth. Notice the apical lucency on this tooth and the adjacent tooth. What's the reason for that apical lucency? If we take a look at this periapical radiograph, you'll notice there's an apical lucency here. If we take a look at the mobility, there's a class 2 mobility in both those teeth. Let's take a look and see if, in fact, the patient is gaining incisal guidance, and you'll notice the arrangement. This is almost a class 3 arrangement. The lower teeth have lost almost 60% of the bone, and look at how they're contacting the upper anterior teeth. Is the patient gaining any guidance at all? No, this is primarily a trauma from occlusion situation. So as you look at this, the radiolucency is actually a widening of the periodontal ligament space. It is not an endodontic problem. Therefore, we have to look at this from a functional standpoint, not from an endodontic standpoint. Certainly, we should do pulp tests on these teeth, but the pulp test will be vital on a tooth like this. How do we determine whether a tooth is restorable? A tooth is restorable when the shoulder or the chamfer is at the gingival margin. If we have to bury the margins, that's called impingement upon the attachment apparatus. Can we make this tooth restorable? Absolutely. We can do that with a crown lengthening procedure or a root reshaping procedure that will allow us to place the gingival margin in the correct position. But the patient's biggest concern is the lower anterior teeth. What do we do about that? And as we go through this, let's look at that and understand that incisal guidance doesn't always exist. We'll note when the patient slides forward, she's actually catching on teeth numbers 8 and 9. Notice tooth number 8 is a little bit longer than tooth number 9, and therefore tooth number 25 is taking a little bit more stress than tooth number 24. This is important. This lower tooth is infremitus, and our first goal is to balance out the occlusion so the patient isn't infremitus. Let's take a look at tooth number 3, and notice right here you see a patch on that tooth. So that means likely that the tooth was crowned and then recurrent caries occurred, and the patient then needed a patch. The endodontic treatment is done well. There's no apical lucency whatsoever, but certainly this tooth has been restored more than one time. If we take a look at the adjacent tooth number 2, that tooth does not have any endodontic treatment, but take a look here. You'll notice that there's caries on the mesial aspect of that tooth. Now, sometimes that can be an open margin, and what we'll do is take and explore in that region, and as you know, if it sticks, then there's caries in that area, and sure enough, there was a stick on that tooth. There was also a stick underneath the margin of tooth number 3. So what's your decision there? If you like what we're doing on practical treatment planning, please like, subscribe, and share this video with your dental colleagues. This will improve our YouTube prominence. Let's take a look at tooth number 14. Tooth number 14 has an apical abscess on the mesiobuccal root. The patient gets an occasional pimple in that area, which drains every once in a while. She doesn't get a salty taste. But certainly this is a failed root canal on this part of this tooth. Now take a look now at tooth number 18. Number 18 also has an apical lucency, and if we take a look at this tooth, we notice also an apical lucency in that area. Understand the patient is depending now primarily on posterior function. There is no anterior guidance. There is no canine guidance, and therefore there's going to be an occlusal slide. We need posterior teeth in contact. Sometimes we say second molars are expendable. In fact, we see that a lot. There are no anterior determinants here, and therefore we have to maximize the patient's ability to share the occlusal load, and therefore the second molar here is quite important. So then we get to that third and most important question. Has the patient had 2 or more procedures on a tooth that's failed? that's when we should be doing a dental implant. So how do we prioritize this treatment? We prioritize this treatment based on what the patient has told us. She's concerned about the loose lower teeth. What do we do about that? By aesthetically reshaping tooth number 8, we can change the incisal edge length of tooth number 8 to match that of number 9. That will reduce the occlusal trauma on teeth numbers 24 and 25. The next step will be to extract teeth numbers 14 and 18. We can usually do an implant on the very same day with appropriate bone grafting. While that area is healing, the next step is for us to make her a night guard. Which night guard do you choose, an upper or a lower? Well, in this case, we're going to use a lower, right? We're going to splint the lower teeth together. We're going to cover the incisal edges of the lower anterior teeth. So when the patient is going into parafunction or when she's going into protrusive, teeth numbers 24 and 25 are not taking any stress. We'll then proceed on restoring the implants on number 14 and number 18. And now the left side is completed. Notice we're leaving her with the right side to function on while we're doing the left side. Could we do it all at one time? Yes, we could. And the patient has that choice of doing all of the work on the left side and the right side all at the same time. In this case, she's choosing to have the right side to function on while we're restoring the left. And that's not a bad decision at all. What do we do on the right side? Well, tooth number 3 has had a great deal done to it. This falls into the category of 2 or more failed procedures on the tooth. What we're going to do first is to remove the crown on tooth number 2, excavate caries, and place a temporary crown on that tooth. Then we go to surgery, we'll extract tooth number 3, and we'll do a crown lengthening procedure on tooth number 2. When we extract tooth number 3, if we can, and if there's sufficient bone, we'll place an implant on the very same day. So now she's completed all of her surgery on that side. The next step will be to uncover the implant tooth number 3. And then we will complete the preparation on tooth number 2. We'll do a preparation on tooth number 30, which has a fractured distal buccal cusp, and do a crown preparation on that tooth. And then we'll restore teeth numbers 2, 3, and 30 all at the same time. The final step is that lower night guard that splits the lower anterior teeth and allows the posterior teeth to touch. That will splint the teeth in place. It will also help to keep the lower anterior teeth from crowding. And that's it. You know, there are times when we can take these cases and we can do them a step at a time, as we did here, or patients will say, I want to get it all done at once. We want to get the surgery done at once. When we do that, we depend on the night guard to distribute the occlusal load while the teeth are getting back into function. And, you know, it's going to be 6 months, 8 months before the function is complete. As long as the patient has the understanding of what is going to ensue, what's going to happen, then the patient can make the best choice for him or herself. Some of our patients have chosen to get all the surgery done at one time, and that way their dentistry is all done. As a matter of fact, in my career, that happened more times than not. And there's some people who say, you know, I really want that side to chew on so that I can function on one side while it's healing on the other side, and then I understand I'm going to have to go through another 8 months of therapy in order to be able to get it done on the other side. The point is to do this a step at a time. Always take your priorities, and the priorities are infections first. Get those infections taken care of first. Move forward. We call those the have-tos. The have-tos are the infections. What are the infections? They're the apical lesions, they're periodontitis, and they're caries. Those are the have-tos. And then the want-tos is what we do to decorate the teeth. What do we do to restore the teeth? Those are more want-tos, and as long as we can separate that out, the have-tos from the want-tos, the patient has the opportunity of making choices, really defined choices, choices that they can think with, and they can make the best decisions for themselves. If you want to see more about crown lengthening and root reshaping, take a look at this video.